Is it achalasia cardia? Achalasia? Or you are thinking scleroderma, like, yes, joint pains in her, yes. Okay, you are right. I completely missed the joint part. So this patient, okay, this patient has a number of findings: esophageal dysmotility, fibrotic lung disease, arthralgia consistent with extradermal manifestation of systemic sclerosis. Classic early manifestation of systemic sclerosis include thickening or hardening edema, thickening or hardening edema, and pruritus. However, if skin symptoms are mild, patients may first seek attention due to gastrointestinal, joint, or respiratory disease. GI complications are common in systemic sclerosis and primarily affects the esophagus. Systemic sclerosis causes smooth muscle atrophy and fibrosis in the lower esophagus. The upper third of the esophagus is made of striated muscle and seldom affected by systemic sclerosis. Common symptoms include dysphagia, choking, heartburn, and hoarseness. Esophageal manometry is affected. Esophageal manometry in affected patients typically has hypomotility and incompetence of the lower esophageal sphincter. Okay, okay. Achalasia. Achalasia presents with dysphagia and regurgitation of undigested food, as in systemic sclerosis. Manometry shows peristalsis in the distal esophagus. However, achalasia causes increased lower esophageal sphincter, incomplete lower esophageal sphincter relaxation, whereas systemic sclerosis causes decreased lower esophageal sphincter pressure. Okay, increased lower esophageal sphincter. In achalasia, there is increased lower esophageal sphincter pressure, and systemic sclerosis there is lower. Okay, this is the one differentiating point, and another one is joint pain, which is very important. Okay, in box. Okay, systemic sclerosis pathogenesis is progressive tissue fibrosis, vascular dysfunction, tissue fibrosis, vascular dysfunction. Clinical feature: skin skin telangiectasia, sclerodactyly, digital ulcer, calcinosis, cutis, extremities, arthalgia, myalgia, contracture, gastrointestinal tract, esophageal dysmotility, dysphagia, acid reflux, lungs is dyspnea, dry cough, vascular system, Raynaud's phenomenon, autoantibody, anti-nuclear, anti-topoisomerase 1, and anti-centromere antibody. Diffuse variety anti-topoisomerase 1 or anti-HCl70, and limited variety is anti-centromere antibody. Complication: lungs, interstitial lung disease, pulmonary arterial hypertension, kidney hypertension, scleroderma, renal crisis, severe hypertension, AKI, MAHA, heart, myocardial fibrosis, pericarditis, pericardial effusion. Right. Right. So is it Lyme disease? Is it IBD? It's uveitis. Oof, it was easy. Okay, this patient has likely GIA, a chronic this patient has likely GIA, juvenile idiopathic arthritis, a chronic inflammatory condition of the childhood. Oligoarticular GIA, the most common form, is characterized by involvement of less than 4 joints within the first 6 months of the disease onset. A limp a limp that is worse in the morning in a toddler girl, such as in this patient, is a type of presentation of the oligoarticular GIA. Joint swelling is present, but pain may be minimal. The large joint, knee, ankles are the most commonly affected. However, hip involvement is rare. Systemic symptoms, fever, rash do not occur. Uveitis, intraocular inflammation is a serious complication that develops in a minority of the patient with oligoarticular GIA. Ophthalmologic screening examination are performed regularly because untreated uveitis is often untreated uveitis is often asymptomatic and can lead to irreversible vision loss. Although not present in all patients with oligoarticular GIA, and nuclear antibody are a risk factor of uveitis. Additional lab findings, leukocyte count, hemoglobin, erythrocyte, ESR are typically normal in oligoarticular GI. Treatment aimed as relieving pain, treatment aimed as relieving inflammation and includes NSAID, anti-inflammatory drug, intra-articular glucocorticoid, and disease-modifying anti-rheumatic drugs. Okay, next. Yes, okay. Systemic GI frequency is 10%, age onset less than 18, arthritis with one or more than one joint, arthritis with one or more than one joint for 6 weeks, quotidian fever for more than 2 weeks, evanescent rash, hepatosplenomegaly, and lymphadenopathy. Male-female ratio is equal. Polyarticular frequency is 40%, age 2 to 5 or 10 to 14. Arthritis in more than 5 joints may be complicated with uveitis. Female is more than the male. And oligoarticular 50%, age 2 to 4. Arthritis less than 5 joints may be complicated by uveitis. Female is more than the male. Okay. Okay. These patients' clinical features are worrisome of iatrogenic septic bursitis. Iatrogenic septic bursitis presenting with acute pain following an initial positive response to following an initial positive response to corticosteroid injection. Subacromial injection are used to treat subacromial bursitis, rotator cuff tendinopathy, and adhesive capsulitis. During this procedure, the needle penetrates the subacromial bursa deposits, depositing corticosteroid into the bursa near the supraspinatus tendon. However, injection can introduce skin flora, staph aureus, and strep pyogenes into the deep structure. Ideally, manifestation infection typically manifests as worrisome pain, redness, swelling, systemic symptom, fever, myalgia, several days after the procedure. In contrast, post-corticosteroid injection flare. Post-corticosteroid injection flare is steroid-induced chemical synovitis typically occurs rapidly and resolves within 48 hours. In some cases, the bursa communicates with the glenohumeral joint capsule, and septic bursitis may progress to septic arthritis. When infection is suspected, an image-guided ultrasound of the bursa or joint is necessary to assess for infection. Okay. Yes. 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 In fibromyalgia, we tell the patient to swim. We tell the patient to exercise. Swimming is the best exercise for the patient with fibromyalgia. Okay. So this patient's presentation is consistent with it. This patient's presentation is consistent, likely fibromyalgia. Fibromyalgia presents most commonly in young to middle-aged women with widespread pain, fatigue, and cognitive or mood disturbance. Patients tend to have fairly normal physical examination, except for point tenderness in an area such as mid trapezius, lateral epicondyle, costochondral junction in the chest, and greater trochanter. Fibromyalgia has no specific diagnostic lab findings. Revised 20 10. American College of Rheumatology criteria using widespread pain index and symptom severity scale rather than trigger points for diagnosis. The index and the scale better emphasize cognitive problem, fatigue, and severity of somatic symptoms. Initial management of fibromyalgia involves multidisciplinary approach including patients' education about fibromyalgia, regular aerobic exercise, and good sleep hygiene. Education requires validating that fibromyalgia is a benign condition with a favorable prognosis. Although patients may complain of increased short-term pain during or after activity. A regular exercise program, aerobic conditioning, strength training, stretching improves long-term pain. Water exercises water exercise can gently reduce the pain. Medication tricyclic antidepressant are reserved for patients failing initial measures. There is limited evidence for other approaches include trigger point injection, analgesic, alternative therapy, tai chi, yoga. Okay. Okay. These adolescent these adolescent with right groin pain has a Trendelenburg sign, a drooping of contralateral pelvis that occurs when standing on the affected leg. The associated Trendelenburg gait, often described by the patient as limp, and is caused by compensatory shifting of the trunk to maintain balance during ambulation. And these findings are non-specific and represent gluteal muscle weakness. In this patient, the most likely cause of The most likely cause is slipped capital femoral epiphysis or slippage of the femoral head from the femoral neck through the growth plate. Slipped capital femoral epiphysis classically presents in adolescent with chronic progressive pain of the hip, groin, or knee. Examination showed decreased abduction or internal rotation of the hip as seen by these patients externally rotated foot. Although it is common in obese children, slip capital femoral epiphysis can occur with no risk factor atrophy of the quadriceps and gluteus muscles due to chronic disuse may be easier to visualize in children with a lower BMI as in this patient. The first step in evaluation of slip capital femoral epiphysis is hip X-ray, which should be bilateral because the contralateral hip also be affected. Posterior displacement of the epiphysis from metaphysis. Posterior displacement of the epiphysis from the metaphysis confirms the diagnosis. While other suspected conditions causing Trendelenburg sign, developmental dysplasia of hip, avascular necrosis of the femoral head also warrant bilateral hips X-ray. Okay. Okay. Supracondylar fracture of the humerus are the most common elbow fractures in children. Are most common elbow fractures in children. The mechanism typically involves a fall on outstretched hand with a hyper fall on outstretched hand with a hyperextended elbow. The supracondylar area is relatively thin and weak due to physiologic remodeling during childhood, and a supracondylar fracture most commonly results in posterior displacement of the distal humerus fragment as seen in this patient. The anteriorly displaced proximal fragment can entrap the median nerve and brachial artery, which are located anterior to the humerus. Distal perfusion should be monitored closely because the brachial artery injury results in diminished brachial and radial pulse. Motor and sensory function should be assessed due to risk of median nerve injury that can present with weak OK sign that can present with weak OK sign. Diagnosis is based on X-ray, which reveals a fracture line. Diagnosis which reveals the fracture line and often indicative posterior fat pad indicative of elbow effusion. Treatment involves analgesia, immobilization, Neurovascular injury often resolves after orthopedic alignment and immobilization. Patients who are treated promptly Patients who are treated promptly have a good prognosis. Okay. Okay. This patient has bilateral hand arthritis with an inflammatory changes on X-ray, bone erosion, osteopenia, mild anemia. This presentation is consistent with rheumatoid arthritis. Disease-modifying anti-rheumatic drug can improve long-term joint function and initiated as soon as possible after the diagnosis. The patient oral ulcer, liver function tests abnormality are likely the side effect of the methotrexate. The preferred first-line DMRs for the treatment for most treatment with RA, rheumatoid arthritis. The anti-inflammatory properties of methotrexate are mediated largely by inhibition of the dihydrofolate reductase, which causes cellular folate depletion. This leads to impaired DNA synthesis and effect that is most pronounced in appropriately dividing cell. Therefore, side effect in oral ulcer stomatitis and bone marrow suppression, macrocytic anemia, bone marrow suppression, macrocytic anemia. Methotrexate is also associated with hepatotoxicity, which can range from mild elevation in hepatic transaminase to chronic liver disease and cirrhosis. Much of the toxicity, including hepatotoxicity, stomatitis, can be mitigated by concurrent administration of folic acid, which does not reduce the effectiveness of the drug. Oh, yes, methotrexate, it's a folate antimetabolite, folate antagonist. It can cause adverse effect is hepatotoxicity, stomatitis, and cytopenia. Hepatotoxicity, stomatitis, and cytopenia. Leflunomide, pyrimidine synthesis inhibitor, it can cause hepatotoxicity and cytopenia. Does not cause stomatitis. Hydroxychloroquine, TNF and interleukin 1 suppressor, TNF and interleukin 1 suppressor. It causes retinopathy, sulfasalazine, TNF, and interleukin-1 suppressor. It causes hepatotoxicity, stomatitis, and hemolytic anemia. Hepatotoxicity, stomatitis, and hemolytic anemia. Anti-TNF alpha inhibitor, infliximab, adalimumab, golimumab, certolizumab, etanercept. It can cause infection, demyelination, congestive heart failure, and malignancy. Okay. Okay. This patient most likely has Achilles tendinopathy. Achilles tendinopathy is often referred to as tendinitis through inflammation and is not always present. Achilles tendinopathy occurs most commonly in patients who abruptly increase athletic activity, particularly in running and jumping sports. The risk is also increased for use of fluoroquinolone antibiotics. The risk is also increased following use of fluoroquinolone antibiotics, and these patients have increased risk of tendon rupture. Okay. Tendon rupture. The diagnosis is based primarily on the clinical finding: Achilles tendinopathy, ankle pain, swelling, tenderness that are usually most prominent, approximately 2 to 6 centimeter proximal to the insertion of the tendon, where perfusion of the gastrocnemius and Achilles tendon complex is the lowest. Management of Achilles tendinopathy primarily includes activity modification, cold compressing, cold compresses, icing, NSAIDs, anti-inflammatory drug for chronic symptoms, rehabilitation program emphasizing eccentric resistance exercise, lengthening of the muscle while under load is recommended. Okay. Okay. This is Behcet's disease. This patient has characteristics feature of Behcet syndrome. including recurrent painful oral and genital recurrent painful oral and genital aphthous ulcer and uveitis and erythema nodosum, tender red nodules usually in the pretibial area. These patients are also at high risk of valvular disease vasculitis with venous and arterial thrombosis. Patient may also demonstrate lethargy, an exaggerated ulcerating skin response following minor injuries. Needle stick. Behçet syndrome is more common in, in patients of Turkish, Middle Eastern, and Asian descent. The diagnosis is made based on clinical feature and lab evaluation and is primarily directed to ruling out other disorder. Biopsy of the affected tissue is not usually needed but may show non-specific vasculitis, often involving small or medium-sized vessel. Okay. What is BMI? So, what is your diagnosis? Anorexia. Yes. Okay. Okay. These patients low body weight BMI 18.5, BMI less than 18.5, stress fracture, and distress in response to recommendation to limit the physical activity are concerning for anorexia nervosa. Anorexia nervosa is common in female patients. Male patients are also affected and are at risk for bone loss, decreased BMD, which is caused by a number of factors: endocrine abnormalities, hypercortisolism, growth hormone resistance, resulting in results in an increased risk for bone fracture. Other medical complications associated with anorexia nervosa uh, include bradycardia, hypotension, and cardiac atrophy. The most common next step in the management of this patient is to obtain comprehensive dietary history, caloric intake, and meal patterns attitudes about food and weight, and history of binging, and efforts to control weight with compensatory behaviors, exercise, fasting, self-induced vomiting, misuse of laxative diuretics should be assessed. In addition, anorexia nervosa in male patients may present with a focus of muscularity rather than thinness. In these cases, dietary history may reveal dietary restriction aimed at muscle building and the use of protein supplementation as the expense of balanced nutrition. Okay, okay, we can stop here. Bye bye.